This is Dr. Otto Janke with the New York Chiropractic Council. Our noted guest for today, I've actually taken classes with him. I've taken courses by him more than once. And we'll talk about a number of that stuff coming up in just a little bit. He's from, it must be in the Bahamas right now. The wind's blowing behind him, but his hair's not going at all, which is technology right there. This is Dr. Christopher Kent. Dr. Kent, great to have you with us today.
Well, thank you. I appreciate the opportunity to share.
Absolutely. Absolutely. So first of all, what's your role at Sherman right now?
Well, I'm a professor and I'm director for scholarly activity. So essentially my focus is on teaching courses associated with research and evidence-informed practice and overseeing some of the research activity that's going on.
So let's dive into this a little bit. Is there research out there, because we're going to dive hard into this right now, is there research out there to substantiate the vertebral subluxation complex?
Oh, absolutely. One of the exciting things about life in today's chiropractic world is that we do, in fact, have technologies that are available that many individuals can use. They're practical. They can be employed in clinical practice. And we'll see if we can get the screen share working here and get into that in a little bit greater depth.
You got it.
Do you have the screen? Got
Absolutely.
it? Perfect. Okay. So vertebral subluxation, what are we talking about? We really have to define our terms because there's a lot of weird stuff going on today. And not everyone really understands vertebral subluxation. They suggest that it's the same as joint dysfunction. And although there may be some relationship between altered joint function and vertebral subluxation, they're certainly not the same thing.
So do we have a definitive definition of subluxation?
Well, we have several possibilities. Let's talk about that. Back in 1927, Stevenson defined subluxation as the condition of a vertebra that has lost its proper juxtaposition with the one above, the one below, or both to an extent less than a luxation, which impinges nerves and interferes with the transmission of mental impulses.
Right.
And that's what we call a conceptual definition. But what we really need as clinicians is an operational definition. And an operational definition addresses how do you do that? How do you find loss of juxtaposition? How do you assess occlusion of an opening and so forth? So we have to kind of look at what technologies we have available. And we have some very useful ones. Again, some of these are more for research, but they're gradually making their way into clinical practice. This is a cone beam CT scan, and it uses very little radiation. It involves three-dimensional imaging as one of the options. Lots of really neat things you can do in image reconstruction. But what I'd like our audience to see is just take a look at the atlas, at the arrow here. You can see that there's a very significant rotational malposition of atlas.
Yes.
And that if we move down the cervical spine, we can see other stuff. We can see some wedging here. We can see an alteration of the normal curve. So this allows us to see in very good 3D perspective what's going on.
Amazing.
So we have to ask ourselves, well, what things should we measure in clinical practice? And there are two aspects to measurement that are important. The first is reliability, and that's just repeatability. If you do it and I do it, well, we probably agree on the findings. That's pretty simple and straightforward. The second is validity. And validity is a little trickier because that's the question, are we measuring what we claim to measure? And that can be kind of context driven. Let me give you an example.
Right.
When I was doing some of the work in developing the surface EMG technology, I was speaking to an individual at a chiropractic college, a so-called researcher, and he said, surface EMG, that isn't valid. And I said, well, valid for what? And he said, it doesn't measure pain. And I said, no feces, Sherlock. It's a motor nerve test, you know? And, and it's like I said, look, you have to use the right tool for a right job. You can't weigh a patient with a rectal thermometer, but it might have clinical utility in an appropriate context. So validity is valid for what? Are we measuring what we claim to be measuring?
Right.
So when you look at the various definitions of chiropractic that are out there, both conceptual and operational, they all basically have two parts in common: some kind of biomechanical phenomenon and some kind of neurological phenomenon. So if we look at biomechanics, some of the tools that we have available that are very good are X-ray spinography. There are X-ray protocols that are reliable and that have been shown to be responsive to chiropractic care. Computed tomography, you know, that we're all familiar with the old-fashioned kind. The cone beam is kind of exciting because there are some practicing chiropractors that have it in their office.
Yep.
Others will refer to dentists who often use it to produce images for them, but it allows us to see these very spectacular 3D renderings. And you can also produce images that look very much like conventional X-rays. Basically, electronically create almost any view you want.
Right.
And then do line drawing and measurements and other cool stuff. Then we have MRI, including weight bearing and kinetic. You know, in the old days, you would just lie on your back, and that's really all that was available. Today, several manufacturers offer upright MRI, which for chiropractors may reveal some structural aberrations that are not evident in the supine films, and also kinetic MRI, motion MRI. Biomechanical assessments, if we go to lower tech stuff, where the only tool you really need is your eye, maybe a camera if you want to do a better job, we have postural assessment and dynamic range of motion. So those are some of the tools that we can use to assess spinal biomechanics. Now, this is the part where most chiropractors fall down,
Right.
and that's the neurological assessment. A lot of chiropractors do little more than a traditional neurological examination, which really in the context of vertebral subluxation is very limited. Back in the 1920s, chiropractors were involved in thermography. BJ developed the neurocolometer in collaboration with Dossa Evans, an engineer, and they started looking at the relationship between neurological dysfunction and changes in skin temperature patterns along the spine. And today, of course, we have infrared thermography, far more sophisticated technology. We can compare the patient's findings to that of a reference database. We can look at symmetry. We can come up with scores that quantitate the nature of the problem. We can look for patterns. Very exciting stuff. So thermography is looking primarily at sympathetic activity.
Let me ask you, why did BJ, why did he come up with thermography, or what was his attempt to use it? What was the impetus to do that?
Well, the story goes that part of the protocol in the old days for examining a patient was to take the back of your hand, hold it very close to the patient's spine.
Yes.
And bear in mind, in those days, patients were gowned.
Yes.
You know, you don't do this through someone's overcoat. So, you know, you run the back of your hand close to the patient's skin. And he said you could feel areas of heat,
yes.
Which he hypothesized. He said they were similar to the hot box on a train. And, you know, a train had gears and things that could overheat. So this was an analogy that seemed apt for the time. And Dossa Evans said, you know, I think we can quantitate this. I think we can make an instrument that measures it. So he came up with the neurocolometer, and shortly thereafter, the neurocalligraph, so that a permanent record could be made of the readings.
When was the correlation made between thermography and the autonomic nervous system then? Way back then?
Depends on who you read. Yes, there was some knowledge of that. Actually, it goes back to the time of Hippocrates. He didn't understand the autonomic nervous system, but he did understand that visceral disease was associated with thermal changes along the spine. And then as our understanding of the autonomic system became greater, that was the mechanism that was speculated to be associated with it. Originally, they thought it was a hot nerve, that if a nerve was impinged, it would give off heat.
Yep.
Yep. So if we then look at the motor part of the vertebral subluxation, the taut fibers, the muscular imbalances, these can be evaluated with surface electromyography. Algometry is nothing more than pressure pain sensitivity. You've probably had an experience, I think every chiropractor has, just about every day had that experience where you say, tender here, oh yeah, gee, I didn't even know that hurt.
Right.
You say, feel better? And they say, oh, you're not pressing as hard. Well, algometry keeps you honest by measuring how much pressure. Heart rate variability, very exciting technology, because here we're looking at how effectively the nervous system is in adaptability. We're looking at the relationship between the sympathetic and the parasympathetic nervous system, and we're looking at how well the body controls it, how much adaptive capacity the patient has. So this is very exciting because it helps to take people out of the local pain model into a global function model. And I can't overemphasize the importance of that. The other exciting thing about heart rate variability is that it's used in many different disciplines. Originally, cardiologists were interested in it, obviously, and now we have studies showing relationships between heart rate variability and metabolic syndrome, even cancer prognosis, things like cognitive ability. All of these things are associated with HRV. And the exciting thing is there are a number of studies showing favorable changes in HRV following chiropractic care.
Yes.
Functional MRI is another exciting technology where instead of just looking at the anatomy, we're looking at patterns of activation. As the neurons metabolize, they consume oxygen and glucose. So we can look at the change that occurs when we go from hemoglobin to deoxyhemoglobin, because what carries oxygen? Iron, right? We can see that on the MRI. By the way, the glucose is a PET scan, but that involves an injection of a radioactive tracer, whereas the functional MRI doesn't require anything in terms of an external agent. And then we have, the conventional neurological stuff that some of you may have had done by referral, things like evoked potentials.
Yep.
And all of these are ways of assessing the neurological component of the vertebral subluxation.
And easily 4 of those we can have in our office at any time.
Yeah, they're very feasible to have in your office. So, there are a number of neurological mechanisms. I don't have time to go into all of them, but cord compression, adverse cord tension, things that are associated with alterations of spinal curves. Of course, the classic nerve root compression, local irritation, which can lead to inflammatory chemicals such as substance P and histamine. And by the way, this is one mechanism by which a person can have pain that's not of dermatomal distribution.
Right.
Vertebral artery compromise, autonomic dysfunction. We're starting to see some research done between coherence and oscillatory patterns in the nervous system, diurnal variations, and all kinds of fascinating stuff. And then disafferentation, which refers to afferent input, how the body perceives itself in the environment.
Yeah.
And very closely related to all of this stuff is the concept of neuroplasticity. We've known that the body is capable of rewiring itself. But even more exciting is the fact that there are actual anatomical changes that can occur as well. So, when I went to school, we were taught the rather depressing paradigm that, you have so many brain cells, and when you get old, they die, and, it's a one-way thing. They don't reproduce. So you just keep going downhill. Well, how inspiring. That's almost as bad as the model that you're a slave to your genetics,
Right.
what they call the dogma of genetic determinism. And thankfully, I had the opportunity early on to meet with Bruce Lipton, whose book, The Biology of Belief, refutes this very nicely. And he talks about how it's the expression of your genes, which genes are turned on and turned off, which is a function of your lifestyle choices and the whole dynamic of your environment. So his work, there was also a pivotal paper published by Dean Ornish in men who had prostate cancer
Yes.
that declined treatment, showing changes in genetic expression, literally hundreds of genes changed in expression as in relationship to his lifestyle alteration program.
First
So
of all,
we're seeing that we have control over a lot of things that we thought we were just stuck with. And it all ties back to vertebral subluxation and how the body perceives itself and its environment.
First of all, when did you graduate from chiropractic college?
You really want to know? 1973. People say to me, why did you go to Palmer? Why didn't you go to Sherman? Didn't exist. Why didn't you go to Life? Didn't exist. Why didn't you go to Life West? Didn't exist. Did you consider Parker? Didn't exist. So there you have it.
Second
When
of all,
I
what was
entered the profession, there were only about maybe 15,000 practicing chiropractors.
what in the main focus of the terminology was it cord compression itself? Was it the bone out of place?
Well, the idea was that when there would be a bone out of place, which we could evaluate with X-ray, that this would disrupt the function of the nervous system.
Correct.
And in Stevenson's textbook, later, people talk about the 33 principles, that's in the early part. That's not even in the freshman text.
Right.
Later on, they talk about cord pressures as well as intraforaminal pressures. So a lot of exciting stuff there. And one thing that I love about Stevenson's textbook is that he talks about how, and this is kind of my interpretation, not his exact words, but they were bound by the technology of the times.
Right.
And
right.
he said, we have valency at an atomic level. We have, he didn't even talk about weak and strong force at that point. He said, we have electromagnetic signals. We have this and that. And he said, who are we to say that we know it all?
Correct.
There may be others we're unaware of. Goodness, a scientist 150 years ago, did X-rays exist before Röntgen? Yeah, stars were producing them. We didn't know, we didn't have the technology. Double helical structure of DNA, did that exist before Watson and Crick? Yeah, and again, we can go on and on. But the exciting thing about traditional chiropractic philosophy is that despite the limitations of terminology and technology, many of the concepts are now being embraced by science. I consider myself very fortunate to have been invited to a number of international medical symposia, which they thankfully allowed me to do virtually. But the cool thing is, they're coming to me and they're not saying, "Quit, go home, there's no subluxation." They're saying, wow, you have a way of implementing a lot of the stuff that we're talking about. So if we look at these mechanisms, we have, again, disafferentation, body's perception of itself in the environment. Dyskinesia, this relates to voluntary motion. Why do major athletic teams, professional groups, Olympians, why do these people go to chiropractors? Because they want a trainer to rub on something that hurts? No, because they want to improve their performance where fractions of a second make a difference. So when you throw the ball and it doesn't go where you want it to go, there's a disconnect, and that could be referred to as dyskinesia, compromised voluntary motion. Dyskinesis is the tonic stuff, the stuff that's going on in the background that you're not aware of. You're sitting up and I'm sitting up. And why are we both sitting up? Well, why aren't we quivering blobs of protoplasm collapsed in our chairs? Because this tonic activity in our paraspinal muscles is holding us up. When there are errors in energy expenditure, secondary to vertebral subluxation, that leads to altered tonic activity. And the fascinating thing about dyskinesis is that it was a term proposed by some people in mental health who noticed that individuals with specific problems had specific changes in posture and gait. And they said, well, how can we measure this? And they said, well, let's try surface EMG. So they came up with this very elegant construct, and then it just seemed to die. And I talked to one of our engineers who has been around a while, and I said, hey, whatever happened to dyskinesis? And he kind of smiled and he said, you can't fix dyskinesis with couch time or psychotropic drugs. So, they couldn't do anything about it.
Right.
But in any event, it's a very elegant model for chiropractic. Dysautonomia is abnormal autonomic activity. And a new thing that we're just starting to see studied in greater depth is what's called aphaptic transmission. And that's non-synaptic communication. In other words, field effects where an electromagnetic field surrounding one nerve influences another one, even in the absence of a synaptic connection. So that's cool stuff.
This last one is a new term to me.
Yeah.
And so that is, are we talking about the space between?
Well, there may be very close contact, but yeah, it's a field surrounding it where there's no synapse. It's kind of like, I'm trying to think of, I don't know if anybody's old enough to remember, old-fashioned stereo equipment and so forth, where sometimes there'd be a leakage of signal, or you'd have it switched to one input, but if you turned the volume up all the way, you could kind of barely hear something because it was leaking in. Yep. It's that sort of thing.
I've often wondered about that because we can easily understand the nerve that goes from there all the way down to there, and we can wire that out. We can see that very simply, but there is just way too much information that goes on inside of us that is not a direct connection. And I've been wondering about that for 15 years, wondering what that was called and how it was. And and
that's part of it. And if you and what people always ask me, well, which one is correct? Which one is operative in a given patient? And the answer is any or all. One does not preclude the other.
At the same time.
One kind of peak experience for me was meeting Karl Pribram. And Karl Pribram is the guy who came up with the idea of the holographic neurological model.
Yes.
And that information is stored in the nervous system holographically. And the cool thing about a hologram is that it encodes information not as a series of dots or pixels like you'd have in an image, a photographic or video image, but rather as wavefronts. And when you look at a hologram and you can move around and see things at a different perspective, it's because it is reconstructing the wavefronts that were present when the thing was recorded. So if we look at this model, which is very heady, it suggests that our frame of reference is everything we've been exposed to in our entire life, and that this interacts with all the incoming sensory information we're currently experiencing to constantly produce new patterns and update the frame of reference. So that's really a wild idea. And they say, well, if that's true, then how do you explain things like Brodmann's area? And you say, well, Brodmann's areas, those are the input and output stations, but the data is encoded holographically. And again, that's theoretical. We don't have the gadgetry to do that.
Let's talk about the different, the same terms we have here.
Uh-huh.
Are we able to quantify or can we measure disafferentation, dyskinesia, dyskinesia, dysautonomia, neuroplasticity, and in effect, can we measure those?
Well, we can assess disafferentation by a number of technologies. One simple one, of course, is algometry, pressure pain sensitivity. There are also more sophisticated means that are probably not terribly practical, like a device called the neurometer, which stimulates dermatomes at different frequencies and determines the threshold of perception. And then you can figure out what parts of the nervous system are involved. But yeah, you can do that with something as simple as a pressure algometer. Dyskinesia, yes, we can look at ranges of motion. We can look at, one study we currently have going on here at Sherman deals with repositioning in people with indicators of vertebral subluxation or not, where they have like a head piece kind of dealing with a laser on it and then a target. And we look at how effectively they can control and position that in subluxated and unsubluxated people. So that's one way of assessing dyskinesia. Another is dynamic surface EMG. That does it nicely. Dyskinesis, static surface EMG, is probably the best technology we have for that, where we're looking at tonic activity in the paraspinal muscles, looking at overall level, looking at left to right asymmetries, and looking at patterns. Dysautonomia, skin temperature, heart rate variability. Now, neuroplasticity is more a phenomenon of the nervous system rewiring itself rather than a mechanism associated with vertebral subluxation. But when vertebral subluxations are corrected, our speculation is that it has a favorable effect on that. Maybe someday, if we have some money, we'll be able to do some fMRI studies looking at connectomes and things like that. And the aphatic stuff, we really don't have much technology available that I'm aware of for that. Again, it's kind of something that's been observed in the laboratory, but we don't have an instrument that does that. So here's a paper, by the way, if you want to read more about that.
Absolutely.
I kind of had some fun with this because there's some folks in chiropractic who say, well, you can't get published in journals if you talk about vertebral subluxation. I said, well, Archives of Neurology and Neuroscience took this. It's right there in the title. Oh, well, it's not in the highfalutin journals. We like, okay.
When you go speak to places, do they see the vertebral subluxation as something brand new to them? And do they also see it as a filling in the blanks for a whole bunch of ideas that they had previously?
Depends on where they went to school. If they went to a school that discusses vertebral subluxation, that uses that terminology and that looks at both structural and neurological function in that context, it's pretty good. Some of the schools talk about it, but don't really develop it as fully as it could be. Then there are those where it's ignored, and then there are the really scary places where it's actually denied. And what I've always said is so many arguments, not just in chiropractic, but in life, are a matter of failing to define your terms. Now, if we operationally define vertebral subluxation and say, if you have a misalignment demonstrated on imaging, if you have autonomic dysfunction evidenced by skin temperature or HRV, if you have aberrant paraspinal muscle activity evidenced by surface EMG, if you have, we can go on and on, palpatory findings. If you have these items, if that's your operational definition, and if those things are there, you got it.
Right.
And, this is done in the healing arts all the time. So it's not really a matter of arguing, does it or doesn't it exist? It's a matter of saying, how do you define it? Do you have reliable and valid means for assessing the components that you're seeking to elucidate? And if you do, you know, there's really nothing to argue about.
So do you think that the majority of chiropractic or the chiropractic profession hasn't utilized or kept up with the technologies at our hands?
Absolutely. Many are not aware of it. Many aren't aware of these mechanisms. You know, just for kicks. It's funny, I said, you know, I'm doing a talk on some of these mechanisms of vertebral subluxation, and I went to the dissection lab and I said, you know, do you guys have any stuff showing whatever? And he said, oh, we'll get it for you. And they just did it. They did a dissection and showed the cauda equina and the filum terminale. They showed the dentate ligament attachments. You know, that's one mechanism of vertebral subluxation involvement that's been proposed by some, that alterations in the tension of the dentate ligaments can deform the cord. And we have some MRI evidence of that. This is very instructive because here at the two upper arrows, you can see the course of the vertebral arteries. You can see that they're kind of different. It's not uncommon for vertebral arteries to be asymmetrical. In mine, I've got one that's like a third of the diameter of the other, and that's not uncommon. And there's a lot of variation in there, and obviously it's a very vulnerable area mechanically. So we can see not only problems associated with pressure on the brainstem and affecting the vagus nerve, potentially affecting the perfusion to the brain through the vertebral arteries. And again, we've seen evidence of that on MRI films. You know, it's very exciting stuff. You know, in this illustration, we can see the relationship between the spinal accessory nerve, the intracranial dentate ligament, the posterior spinal artery, and C1 nerve. And wow, you know, that's a scary area to have a misalignment.
Right.
And its potential impact on one's well-being is dramatic. So here, as promised, the top arrows are the anterior roots. The posterior arrows, the long ones, are the dorsal roots. And the kind of arrowheads you see on the side are the dentate ligaments. So you can see how if those dentate ligaments have tugging, pulling, torsion, that can affect the cord. So again, going back to disafferentation, we can look at what one author called local sensorial conversational tone.
Wow.
And I love that term because it's the two-way communication.
Right.
It's the safety pin cycle. It's the efferent and the efferent. It's the dance between brain cell and tissue cell. And they're saying, you know, in order for things to be working, we need local sensorial conversational tone. And we have all these receptors in the intervertebral motion segment, in the disc, in the meninges, in the posterior joints. We have receptors in viscera. We have cutaneous receptors. All of this data is going into the dorsal root ganglion, and ultimately the dorsal horn. And wow, you know, it's very important, obviously, to the nervous system to have good information about what's happening. So I love that term, conversational tone.
Love that.
So here we see a fluoroscope from the B.J. Palmer Chiropractic Clinic. Thankfully, today we can look at the spine in motion with MRI without radiation. So if we look at this film, you can see that things look pretty good. You know, we've got nice smooth motion. On the next one, however, we have vertebral subluxations. The atlas and axis aren't doing what they should be doing. And you can see back here, kind of in the middle, how we have degenerative material that's causing impact on the spinal cord, you know, as the person flexes and extends. So imagine what's happening, you know, bang, bang, bang. What a way to live life.
Right.
You know, and here's another one that's that's relatively smooth. And if we're dealing with a person with degenerative disease, things get much worse. You know, you see osteophytes on a radiograph and you say, yeah, they got a little bit of spurring. Little bit of spurring. Look at what that little bit of spurring is doing. And notice that the disc spaces there weren't really atrocious.
Right.
We were having impact of those posterior osteophytes on the cord, and that's real bad. And then we talked about functional MRI, or what's called bold imaging, where we're looking at blood oxygen level dependent imaging, so that, as I said, when the cell metabolizes and it utilizes oxygen, we have that change in the magnetization vector. So this is an individual pre-adjustment, and these color spots that you see are areas of activation. Notice that both sides are involved, a little more activity here than here, which is odd, because when you're doing functional MRI, as the name implies, you're having the patient do something.
Right.
Think something, feel something, execute a motor activity. So in this case, it was a simple motor activity. It was moving the ankle, one ankle, unilateral. So we see this, bilateral activation of just everywhere. After the adjustment, notice that it's unilateral, and it's pretty much in the area of the somatomotor cortex on that side, which is what we'd like. So this suggests, and again, this is a single case, we don't want to overgeneralize, but it suggests that in this particular case, it appears that the patient was more effectively utilizing their neural efficiency. And this is a term we're starting to see appear in the literature, neural efficiency. How effectively are we using our neurological resources? And if you look at this, and if you look at a surface EMG on someone, a new patient, they're all tense, they're all tight, the thing is way out of range. What do people say all the time in clinical practice? Oh, doctor, I'm tired. I just don't have energy anymore. Well, look at the energy you're using just to hold yourself up.
Right.
Look at all the energy that's utilized in the brain here to execute a simple movement that should only, have to involve these areas. And if we look at another level, again, look at all those areas of activation. And here, nothing, because at that level, we wouldn't expect motor activity. So there's some pretty exciting stuff going on in terms of technology. A lot of these technologies are available in your office. Much of my professional career in chiropractic dealt with the development of the Insight subluxation station and the technologies of surface EMG, integrating it with thermography, with heart rate variability. And we also had algometry and range of motion available for doctors who were interested in that. So in answer to your question, yeah, we got some great technology.
Use it daily.
Yes. Hans Selye. Got to tell you about Hans.
Hans.
Again, you talk about the stuff from the past. Hans Selye actually spoke at Palmer, and he spent some time with the faculty after, which was kind of fun. And he related a story to us that I think we can all identify with from our chiropractic college days. He was in a differential diagnosis class. And he said the way it was set up was it was in an amphitheater. So on the stage would be the professor and the patient. And the professor would bring in a patient and say, here's the history, here are the imaging findings, here are the labs, what do you think? What are the differentials? How would you determine that they had disease A versus disease B and blah, 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 blah. So Selye said, I was sitting in class and I was watching this parade of sick patients.
Right.
And instead of thinking about what's different, I thought to myself, what do they all have in common? There seems to be something they all have in common. And as sadistic professors are wont to do, the doctor saw that he was kind of wandering off and said, well, Selye, what do you think is wrong with this patient? And Selye said, well, like a reflex, it just came out of my mouth. I said, why, doctor, he's sick. And everybody laughed, they had a chuckle at Cellier's expense, but it got him started on this whole concept of stress and adaptation. And I just love the terminology. Now, this is a guy who's got more degrees than the thermometer. I mean, this is Hans Selye, okay? And look at the terms he uses. Every living being has a certain innate amount of adaptation energy or vitality. How cool is that? And you hear people today say, oh, I wish I had a stress-free life. And I said, well, that's not going to happen until you hit the marble orchard. As Selye noted, complete absence of stress is incompatible with life, since only a dead man makes no demand on his body or mind. When people say they want a stress-free life, I said the only difference between you and the chair you're sitting on is you're adapting. The chair is inanimate. When you stop adapting, you're dead. So the only issue is what's going to be the scope of your human experience. If your adaptive capacity is limited,
right,
you got two options. You can live there, or you can come up with ways to expand that, such as correction of vertebral subluxation so that the nervous system can work without interference. And here's what everyone seems to miss. When Selye talked about stress, he talked about eustress versus distress. And eustress, as in euphoria, that's the good stuff. That's what causes us to grow. Distress is what most people mean when they say stress. That's the negative stuff. That's what throws you into freeze, fight, flight. That's what causes you to be in high sympathetic tone all the time, where you perceive whatever the event is as a threat. But if instead you perceive it as an opportunity, your physiology changes completely, and you now have the ability to expand the scope of your experience and to expand your resiliency. Very exciting stuff.
Yeah.
So what do you need to do that? A nervous system that's free of interference.
Right.
So
Right.
I don't know how much time we have. Time flies when you're having fun.
So let's get back to a couple simple things.
Sure.
Very, very important is that we have an opportunity to, one, as Dr. Chiropractic, analyze all of this, and then pre and post, and then with the adjustment, then to follow up and see how well the nervous system has adapted.
Yes.
And this technology has been around for?
Well, it's evolved. We started with surface EMG, then we added thermography, then we added heart rate variability. So heart rate variability, obvious, all of these technologies were around before we came, but we adapted them to assessment of vertebral subluxation, integrated them, came up with composite scores and things of this nature. And I don't think it would be hyperbole to say that we're the ones primarily responsible for introducing HRV into chiropractic practice and popularizing it.
Yep, I've used HRV almost daily. 2019 was published with a journal, and it couldn't have done it without that. So when you talk about the 4-dimensional model of VSC, are we looking at now a 6-dimensional model?
No, not really. We still have the 4-dimensional model. I just maybe should have put those on separate slides because neuroplasticity and apoptic transmission really aren't something that we can measure operationally at this point in practical clinical work.
So let me ask you a last question for you. And it's
Sure.
this: where can chiropractic grow to? Where can it grow to?
Chiropractic is limited primarily by the public's perception of what it is. As long as the public thinks that chiropractic is an expensive, mediocre treatment for neck and back pain, it will never realize its true potential. But if people realize that chiropractic is about the totality of the human experience, because every dimension of the human experience is processed through the nervous system.
Right.
Every thought, every feeling, every motion, every emotion, every aspect of your life is processed through the nervous system. And what we do as chiropractors is locate and correct the cause of any interference to that process, not merely to relieve pain, which will often happen,
Yes.
but to allow you to express the totality of your potential as a human being in the context of your desires, goals, and dreams. And if we can effectively reposition chiropractic, the cool thing is no one else is doing that.
Right.
No one else is doing it. Do other professions offer spinal manipulation? Yes. Are there
Yes.
other professions offering back pain treatment? Yes. Are there other professions offering lifestyle counseling? Yes. But chiropractors are the only one that does that one thing, the analysis and correction of vertebral subluxations, that can have so much impact on the totality of your life.
So then we get back into colleges that don't teach it, or national organizations that don't. We've done a bad marketing. We've done a bad marketing job within our own profession then.
A horrible job. And, support the organizations that support your worldview.
Right.
Don't empower your enemies. Don't send checks to subluxation deniers.
Right.
Yeah.
Right. Absolutely. Dr. Christopher Kent, we totally appreciate your time, your love, your expertise of chiropractic, and we are glad you are on our team.
Well, thank you very much.
New York Chiropractic Council totally appreciates your time and expertise today. Where can someone follow up with you or follow you or engage with you more?
Well, of course, I have a Facebook page. You can go there, Christopher Kent. You can reach me at ckent@sherman.edu. And if you'd like to find out more about our monthly subscription service, where we keep people apprised of philosophy, science, and politics in chiropractic, chiroonpurpose.com.
Absolutely. Absolutely. Dr. Christopher Kent, we totally appreciate your time, expertise, and love. I'd highly recommend everyone take some time, follow him, and become a fan of what he does. If nothing at all, become a fan of where he has been and where he's going and the research he's putting out. Phenomenal stuff. Phenomenal stuff.
And if you go to the Sherman College site, sherman.edu, and go to the research page, we have links to some of these articles we've talked about.
Yep.
And we also have videos of some of the presentations I've done to medical groups. So that's available to you for free.
Absolutely cool stuff. Dr. Kent, appreciate your time.
Okay, thank you.